Hello everyone, my name is Caroline Andrews and I'm from Verity, the PMOS charity in the UK. And today I'm really excited to have with me today on a webinar Professor Terhi Piltonen from the University of Ula to talk through some myths on cysts, polycysts, ovarian cysts and why the rename of the condition is so important for research, funding and patient care. Professor Terhi Piltonen is also the President of the AE-PCOS Society, so he'll be able to tell us all about the process and the important work that's been done to change the name. So Terhi, over to you, and if you'd like to tell us a little bit about the name change process, that would be fantastic.
Okay, so this has been a very stringent process and project over the years. So there have been several medical experts who actually it was already over 10 or 15 years ago when it was first said that the name should be changed because of the fact that it doesn't really reflect the true nature of this very common syndrome. Really came time to do this change because the syndrome has had an evolutionary profile. The lots of the new things have come along in the research and also the patient care. So now I think it was a momentum really to do this, and this was definitely a kind of a process that was well planned, and thanks to Professor Helena Teed, who has been really leading this project. This was very systematically done, so that with the first we had a mandate where there was almost 8,000. The name altogether should be even changed. And after that mandate, there was a huge questionnaire that involved the patients and their relatives and also different organizations like patient organizations, but also health organizations that are steered by the health professionals. So there were over 22,000 answers how the name should be changed or what the new name should be. So after going through all that and excluding, and there were workshops. So the first step was that there was different options, where should we go? And for these options, there were 90 health professionals and patient organization representative, and they represented 52 different societies. So there were workshops that we kind of narrowed down the different, the options, what the name should be. And in the end, there was after voting and narrowing down, we came up with this the new name endocrine metabolic ovarian syndrome. So it was really a process, but it didn't start from here. There was a demand for it several like decades back, but it didn't happen until now.
A lot has come out around people are saying they've had cysts, they've had cyst ruptures. So there's a lot of confusion around it. So I think if we can sort of first of all address the issue, when we've previously had the name polycystic ovarian syndrome, what were the cysts referring to? So what is the cyst on a polycystic ovary?
I do have to say that the history wasn't really wise because nothing has happened, or it's a long evolution to even have that beautiful ovary. It's more like polyfollicular ovary. So actually the cysts in the ovary, they are small little follicles that are it's very natural to have in the fertile age women ovaries. So that means that there are small little follicles that are situated usually when they are growing a little bit larger. They are in the cortex, kind of on the outer layer of the ovary, so just under the outer layer. And so they are called follicles, and most of them actually have an oocyte in them, so the little egg is in there, ready to be developed forward. And if you look at them in the ultrasound, they are kind of like a small little, because cyst is actually a sac full of liquid, and they are like they kind of a show like that also in the ultrasound. Many of you, when you have gone into the gynecological office and you've had transvaginal ultrasound, you've seen those little sacs that are there, but they are actually not they should not be called cysts because cyst is a larger entity, but these are follicles, and they do have their developmental trajectory where one of them will be now selected for ovulation for kind of a further development. And in the end, when it's big enough, it's about 1.2 centimeters, then the follicle will ovulate. So it will burst out and release the egg. So now that is very, very normal and very common. And there are full of these follicles in the polycystic ovary. But the problem is that one of that those any none of because it's so crowded, there's so many of them, it's very difficult for them to kind of advance in their developmental stage and release that egg. So that's the problem. But if we think about cyst, so usually the cysts are the ones that they might become from those follicles that don't develop it further, but usually that happens in every ovary, not in the PCOS ovary per se, but in every ovary the development can kind of go a little bit, you know kind of a miss on the, kind of like a sidetrack when the oocyte, it kind of shrinks, or there might even not be an oocyte in it like in the first place, and there is just like a fluid sac that gets larger, 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 and sometimes it bursts and causes lots of pain because of the rupture and the liquid that is coming, the from the cyst that will go into the peritoneal cavity and cause pain and irritation. So that's in that sense that can happen during the follicle development, but if PCOS, so there is kind of a like you would even think that sort of a cyst will now appear very easily in PCO in this PMOS ovary. So cysts are kind of like a fluid sacs that are coming and going in the ovary, but they're definitely not the ones that we are meaning when we're seeing a PMOS ovary. That means the little small follicles that are there that have eggs. So it's a completely different thing. And now we have published this just recently showing that if you look at these cysts, in women with PMOS and then women without PMOS, there is no risk for development to develop these cysts in your ovary compared to the women that do not have PMOS ovaries. So we are talking in two different things.
This is where I think there's been a lot of confusion with the name. So if people have been to the doctors, they've had the transvaginal ultrasound, and has it been quite common that those follicles have been called cysts over the last sort of 20, 30 years? And do you think that's where quite a lot of the confusion is coming from?
I think, when people are like, oh, you have these small little cysts here, but, they are not really cysts. They are called cysts when they are larger. So, you would not call a follicle a cyst. That's kind of just I don't know, it's kind of been a cultural, inaccuracy that is there. And now it has caused lots of confusion. Of course, even naming this syndrome with the name cyst, it just doesn't make sense. Yeah.
And you mentioned about the pain there from ovarian cysts. Again, there's been quite a lot of conversation around PMOS causing pain. So, is there a possibility that the follicles can burst, or is it more that the ovarian cysts, if people have those burst? I mean, we're talking two different issues here.
Yeah, we are talking two different issues. So one is that, if you would have, because of course, PMOS ovary can also have cysts. That can happen, but it doesn't happen more often than for the other women. So they can burst, and that would cause the pain. So that's a usually very intensive pain, and it will cause as I said, irritation all over the abdomen because having that fluid there will kind of there will be like an inflammatory process inside the peritoneal cavity, and you can even sometimes you can feel a pain on your shoulder because there is a nerve that is kind of attached to the your diaphragma. So when the diaphragma is getting irritated, you can also feel it as a shoulder pain. So that's completely completely different pain compared to for example, endometriosis related pain. And of course, women with PMOS could also have endometriosis, and that's very different kinds of a pain compared to the bursting of the cyst. But I do have to say that sometimes my patients, they do say that they can feel their ovary. And sometimes I'm thinking that could that be because the ovaries are so tense and they are so large and they are packed with these small little follicles that, it's just like a very kind of a, even how do I say, like mechanical pain in that way, that they are very sore, thinking that if you manipulate ovaries are also, they have lots of nerve endings, around them, so they might be kind of more sensitive. But we don't have any real good data showing that they would be in kind of in like in chronic pain. We do have a questionnaire there. We haven't really looked into the answers yet. We have asked this from our large patient. We have about 4,000 women that we have asked about this. There are half of them are women with PMOS. So we haven't analyzed it, but bursting a cyst is completely than having PMOS ovary that should not have that sort of a very intensive pain.
Is it possible that the imaging, if people were to have an ultrasound at different stages in their lives, that there may be a different number of polycysts on a PMOS ovary?
Yes, absolutely. So that's a dynamic process what everybody experience during their life with the ovarian morphology. So if you look a young person and you look at their ovaries, let's say women under 25 or 20, if you look at their ovaries and you see how they look, they are larger, and there are lots of these small follicles in their ovaries as well. And that's natural. They will definitely, many of them will fulfill the criteria for having PMOS ovaries. And that's why we are not using the transvaginal ultrasonography as one of the diagnostic criteria. So the PMOS ovary diagnostics cannot be applied to young women because so many of them have, by naturally, they have lots of these follicles because, they are young. But when you're getting older, these follicles will now start, they disappear. They actually start disappearing already after we are born. But when we start following them up, you can see gradual decline of these follicles over the years. And then it might be that by the end of age of 35, if you had your first ultrasound at age 25 and it said that, yes, you have PMOS ovaries, and then you have another ultrasound when you're 37 or 35, it might say like, it's very difficult to say whether you actually fulfill the criteria anymore. That's okay, because that's a natural progression of your ovary. So the ovarian follicles have depleted because, by the end of natural for not fulfilling the criteria any longer. But it doesn't mean that you don't have PMOS anymore, because it's much more than just the ovary. So we can do a retrospective diagnosis of you if you fulfill already, if there is a history that, you had the ultrasound, or you had the irregular periods, or you had the hyperanagenism. So you can do the diagnosis even you do not present the exact ovarian morphology at that stage. But it's very natural to kind of not having PMOS ovary when you are heading towards menopausal, premenopausal ages, and this means around the age of 40. But some of them, will still have the criteria still ongoing when they are 40. They're very lush ovaries even that time. So there's lots of individual variation.
Just asking the question around adolescence and with the steer toward the condition now sit with the changes in the adolescence diagnosis.
So there is this, the name change is not going to change anything in their diagnosis. I mean, they didn't have the ultrasound or the PMOS ovarian morphology diagnosis in the first place, So it doesn't change anything. There is the two criteria that the adolescents will have to diagnose PMOS is the irregular cycles and a sign of hyperandrogenism, so old in their diagnosis. So no, this didn't change anything for them in that sense. But on the other hand, the name change will also make it more clear that this is more than just about ovaries. So maybe it's even better now for the adolescents.
The idea of obviously the introduction of the metabolic into the name, how does that fit for what people refer to as lean women with PMOS? Can they still have metabolic issues?
Yes, absolutely. So um, we think that PMOS is originated very early on during fetal development. So you would always have PMOS, but there are different BMI trajectories for women. So some women are lean, actually about 20% of the women are lean. So that would mean that they would have PMOS, but the phenotype is a little bit different. Well, first of all, I think BMI is it's a poor indicator of metabolic stress. I mean, it's not very sensitive. When it's high enough, you can see that there is some metabolic issues, but on those thresholds when you kind of go in the border of being normal weight and overweight, it's not very sensitive. So in PMOS, you will get central obesity very easily, even though your BMI is normal. And that means that there is more accumulation of fat inside your body, kind of around your intestines. And that fat tissue is actually very metabolically not very good because it's very inflamed and it also causes insulin resistance. So it is more likely that when you're lean and with PMOS, you still have that visual fat accumulation that could also be higher waist circumference than normal, even though your BMI is just okay. So yes, you can have metabolic issues and also glucose tolerance problems if you are lean. So we do recommend all women, regardless of BMI, to have lifestyle interventions, and also looking at their blood pressure and glucose and lipids now and then. And then also during pregnancy, you should be tested
Um,
for gestational diabetes. Yeah.
Lovely. And that very much encapsulates that this is not just a condition that affects your ovaries, but there's issues throughout your life course and throughout different areas of your life.
Yeah, absolutely. So the name now with the polyendocrine means that you have several endocrine systems that are affected, and this also has implications on several organs, not only the ovary. Ovary is just one organ, but it's very important in this syndrome, but it's not the only one that is affected. And then there is the metabolic, that really means the glucose or the sugar, well, overall the energy balance. So that includes the sugars and the lipids and also some inflammatory changes as well, because many of our processes are linked to inflammation. And then, of course, the ovary, kind of a saying that, that ovary and the system that is regulating the ovary, and also pregnancy, because that's where the pregnancy originates, usually in natural conception or so that's also very kind of a central here, given the androgens. But the androgens are also secreted outside the ovaries as well. So they're also secreted from the adrenal glands and then also fat tissue. So there are other sources of androgens as well. So then we go back to the polyendocrine, meaning that there are several other hormones and organs that are affected.
The name's changed and there's been this huge international effort involving patients and professionals. Is there a concern that as science develops that the name could change again?
No, not in the near future. No, I don't think so. Of course, if there would be something that would, just absolutely, change things, like profoundly. If we could find like one thing that is just there, maybe then, but over the years we've been doing all this research for tens of years, and we haven't, there isn't one thing that it is. it's a syndrome. It's lots of things. So I find it very unlikely that there would be such a finding that would now turn this into something else.
I don't think any of us are ready for another huge 10-year effort as well at the moment.
Yeah, I think this is a good like now. Like
Um,
this.
so something that's come up a lot is obviously where people now are having this and a lot of the confusion around polycysts and cysts. If they feel that their pain levels are high, they feel that this may be something more, what would you recommend for people to deal with if they sort of are feeling that actually there may be issues around pain with PMOS?
Sure. That's a very good question. So definitely if there is a pain and then now it has to be, of course, assessed by your GP, at least, in many of the or your gynecologist, if you do have regular pains, but it has to be kind of a note what sort of a pain it is, because of course, it might be that you have PMOS, but you also have endometriosis, for example. So usually with the endometriosis, you'll get your pain just a couple of days before you get your periods, and then there is different sorts of kind of like specific pain with endometriosis. It's a pain when there is if you're biking or then if you're hopping, or then it might be during the intercourse or when you are going to toilet, or there are particular kinds of pain that are very typical for endometriosis. So of course, that would have to be ruled out if you are having these pain episodes regularly in your life. But if it's consistent pain, then I think, it's not very normal to have pain all the time. So I think I would definitely, recommend or seeing your gynecologist or your GP for, in depending what is your kind of a health environment or your healthcare environment. So it has to be assessed because it's not normal to have pain all the time. You should not. Yeah, there is probably something else behind it.
And obviously, women can have a multitude of different conditions like fibroids as well, and all
Absolutely.
sorts. So,
Yeah, that's true. It doesn't rule out of other, conditions that we women have. And we have done lots of studies showing that women actually have several different things. Like one of our questionnaires said, that women have about four different symptoms, during, they had, these were about 800 women that responded. So they had all kinds of four different symptoms, and one could be symptoms related to PCOS, but they might also have like heavy menstrual bleeding or pain or urinary incontinence or things like that. So it's very common for us women to have several different, conditions at the same time. That's not very unheard.
how does this actually change the situation for the patients on the ground? So, the name of the condition's changed to polyendocrine metabolic ovarian syndrome. How is that actually, if you've got a patient going into their medical practitioner, what change is going to happen at the moment?
So what I think, well, we hope that, when you go in and your doctors and the nurses and the healthcare professionals, they're more aware that this is now polyendocrine metabolic ovarian syndrome, that they would now approach this and have more holistic view. So thinking that this is just not about only reproduction, because in so many cases, at least in Finland where I am, and I think this applies to many of the other countries as well, that many of the diagnoses actually came from the reproduction units. So IVF units, or the ones who handle people's, women's reproductive problems. And, that's really, really late. And that only applies to women who have, desire to conceive. So that's a diagnostic delay, but also kind of a sidetrack thinking that, actually when you're now seeing your GP and this is PMOS, they would see it as a whole new view. So they would ask you that, what is the most bothersome symptom that you would have and how would you like us to help you? So you would definitely go through metabolic and psychological, and of course, the reproductive, tissues would have to be, regardless whether you want to get pregnant or not. We can come that a little bit later, but reproductive issues should be taken into account. And then looking at the overall health, what are also the other maybe the health conditions that you have, and are they linked to PMOS, and should something be done? But definitely these three areas should be covered now when you are seeing your GP. So I'm hoping more, and we are looking for more holistic care.
And on that holistic care aspect, do you feel that the change of the name is going to potentially open up the avenues in terms of the psychological health? There's been quite a few concerns around, obviously, a increased risk with anxiety, depression. And how does this change in name maybe potential to access better avenues of care for that?
So I think, thinking about the polyendocrine, because also some of these and metabolic, they will also, we know from other conditions that they also link to mental health issues. And of course, ovary, we know that there are hormones that are affected and kind of are causing, we have premenstrual syndrome, or, other conditions also, for example, endometriosis, that are causing mental health issues. So we are hoping that with this more, holistic approach, the mental issues will be also on the table, and there will be lower threshold on talking about them. And definitely now the name change will have a higher awareness of this syndrome. The fact is that why it was not put into the name, I think we can all agree that that's something to avoid stigmatizing, even though there is nothing to be ashamed of if you have psychological issues. It's very common, and most of us will experience some during our life course, but having it in the name, thinking that not all of the women will have psychological problems. We did consider it, but it was very early on where we of course agreed that it's not embedded, or it's not included as such in the name, but it is embedded on those words that now form the PMOS.
If somebody's been diagnosed PMOS, they're not necessarily looking to have children at the moment. What should they be doing to manage their PMOS as a condition itself? What can be done if it's not necessarily looking to deal with the reproductive issues? What can be done to manage the condition?
Even though, let's talk about not wanting to have and establishing you're not wishing for pregnancy right now, but the two coins, or the other side of the coin actually is still contraception, because we have seen in many of the data sets, also in ours, that many of the pregnancies are still occurring spontaneously for women with PMOS. So there are spontaneous ovulations, they just might come very irregularly, and if you do not wish to get pregnant, you should use some contraception. And of course, the hormonal preparations that are used for hormonal contraception are also used to manage the symptoms of besides contraception is the endometrial protection. So women with PMOS, as you are experiencing anovulation, that means that you are not exposed to progesterone. So progesterone is formed by the corpus luteum that forms after the ovulation. So if you do not have ovulation, you will not have corpus luteum, and you do not have progesterone in your body. And that means that the progesterone is not able to kind of rescue the endometrium. So that means the uterine lining, that's where the tissue that you bleed during menses. So that tissue, the endometrium lining, needs protection with the progesterone regularly. So without ovulations, there is no progesterone. So you would need some protection for your endometrium if you are reproductive age women. So that means that you would now have to have these hormonal preparations. And usually we are doing this with the combined contraceptives or IUD or progestin preparations. And they would also now take the contraception part, into, kind of in action. So that would also take care of that part. So even though you do not wish to get pregnant, you would need to have some plan for your contraception if you do not wish to get pregnant, and then also protect your endometrium. So these are the things. But so then, if we are moving away from the reproductive part, we are going for the metabolic part. So there, of course, the blood pressure is one thing. One thing is your glucose, your glucose metabolism, and then one is your lipid metabolism. So all of these three things should be taken or screened and followed up over the years. So it's very important that you don't develop hypertension. We know that women with PCOS, they do develop it earlier than other women. They also develop kind of like a hypercholesterolemia or dyslipidemia early on. And then, of course, there is a higher risk for insulin resistance and type 2 diabetes almost 10 years earlier compared to other women. So these three things are very important for your metabolic health. And then for the psychological health, usually they are anxiety, depression, and then eating disorders. So these three things are definitely the ones that should be maintained. And then weight management and lifestyle, that's something that should be covered for everybody. um, and of course, weight management can be very difficult. We do know that the little energy machineries in the cells are not working the same way as for other women, so weight management might be very, very difficult. So that really means a kind of a multidisciplinary care, so that you'd be able to have very sustainable and realistic goals to kind of manage your weight. And then also there are some very good medical aid, also nowadays, medications, obesity medications that we can offer if you really struggle with your weight. So I think the reproduction, regardless whether you want to get pregnant or not, and then the metabolic ones, and then the psychological ones. Of course, we haven't talked about skin, so maybe that could be the fourth one. That if you have any skin problems, if you're experiencing excessive hair growth, or you are losing your hair, and then we also know, for example, that hidradenitis suppurativa is more common in PCOS. All the skin areas should be also managed, and kind of taking into account with your screening and your regular checkups.
And you just touched on, can we have periods without ovulating? And if so, will the endometrial lining thicken up? And should that be a concern?
Okay, so yes, you can actually, without having periods, it might be that that you have very, very long time without a period, and then suddenly, the axis starts for a while. It just starts, getting more regulatory. So it might be that you've had very long time without periods, and the next step is that you actually do ovulate and you can get pregnant. So that's one of the things that, it's kind of like after lactation, that if you breastfeed, it might be that you don't experience periods for very long time. And the first, that you come into is the ovulation, and then you already are pregnant before getting your first period. So it's very possible that you can get ovulations without periods, but it's very unlikely if you experience very, very long cycles, or you have absent cycles. Of course, the likelihood of ovulating is very low, but it doesn't mean that you wouldn't ovulate now and then. But usually after the ovulation, of course, if you don't get pregnant, you should have periods. So after the ovulation, you should get that corpus luteum that will actually signal that that the endometrium is now protected and it's ready for the pregnancy or the embryo to be implanted. But if there is no embryo to be implanted, then you will get your period. So just after you're getting your period, that, oh, I might have had ovulation here. And if you do not have contraception, it might be that you already get pregnant.
A lot has been said online about, will this actually mean change? And Terhi, you do some fantastic research. So perhaps you could just sort of sum up what this means to you as a researcher, and how you feel that this will be able to change patients' lives in the future for the better.
Yeah, I'm very, very optimistic, and I do believe that this is the only way to go. We are on that spot. I've seen so many times that my grant applications, I publish really well, and my grant applications are not understood. I have to very often kind of previously I had to mask it with something like a hyperandrogenic metabolic, prevalent condition in women, and so you kind of need to kind of piggyback, somebody somebody else, kind of a somebody else's field, you know, to be included in this, you know, bucket of grants where you have more accessible funding or bigger funding part to support your research. So to me, as a researcher, I think this will definitely open doors. And what it also will do, it will be bring people that are already working on these issues, because there are other people, researchers, clinicians that are very interested in pituitary, they're very interested in liver or the fat tissue or heart. You know, all these people will now also get interested in PMOS, because otherwise, you know, previously they might think that, well, it's the ovary. I'm not interested in ovary, but they didn't realize that, you know, this syndrome actually also belongs to their table. So I'm hoping that, you know, us who are really focusing on PMOS, we will get more funding, and we can also do a vaster funding applications in different kind of a. It's a larger table to choose from. It's kind of like a almost like a, you know, having like a buffet that now you can actually eat from many of the things, whereas earlier you were only able to eat from one slot or one food item. And then also bringing other in, you know, into that buffet who are already there. They feel like, oh, I can also look into that one. You know, I can also be interested in PMOS. So I'm very positive that this will make a big change. And of course, I can see also for my patients that they are very, very happy about, you know, they've been very excited about this name change. And many of them have said that now I'm sure that, you know, I can explain this better to my, you know, GP, or, you know, where I'm, you know, for other healthcare professionals. And you know, I think this will really make a big change.
So thank you very much, Professor Piltonen, for joining us today on an extremely busy week. We hope we've answered some of your questions around the difference between ovarian cysts and polycysts, and a little bit more about the name change and what it can mean sort of moving forward in the future. So we hope everyone has a great day, and thank you very much, everyone. Thank you.
Thank you.
Bye.
Thank you. Bye.